Chair of Orthopedics at UNC Chapel Hill, and also the Frank C. Wilson Distinguished Professor of Orthopedics. So thank you for joining us today, Dr. Sanders.
Thank you, Emily. So all of you, I'm sure, will call me Jim over time. So I do see patients over at the Blue Ridge site, and so it's nice to be part of your group, at least in some way here. So I'm going to talk to you about something which is near and dear to my heart, which is about human growth. And the first thing is to talk a little bit about what orthopedics is. And orthopedics actually is very intrinsic to growth, is very intrinsic to orthopedics. It comes from two words, sorry about that, which is orthos and pedos, which means straight children. So there is actually no such thing as an adult orthopedist. That is a misnomer. You don't need to call us pediatric orthopedists because we're the only true ones, since we're dealing with trying to make children straight. So we treat a number of different disorders, all of which you're familiar with, but they're all greatly affected by growth, whether you're talking about scoliosis, capital-femoral epiphysis, etc. Growth is probably the one thing that really distinguishes a pediatric orthopedist from people who do this other specialty, which claims to be orthopedics overall. Human growth is unique. It is different than any other animal. Humans have some incredible needs as they develop, and the biggest aspect of that is the large brain. And because of that, you need to have a match between the mother's pelvis and the size of the child. So the child themselves are born fairly small with this relatively large head. And then as the body begins to catch up and the pelvis can actually reach the proper size, it takes a long time between birth and the time that the child reaches sexual maturity. Again, this is not true for almost all other animals. Humans have an adolescent growth spurt, which all of you are used to seeing. But if you do animal studies, you find that there are really no other animals that have a true adolescent growth spurt in the exact same sense that humans do. And that means that animal studies are of really limited help. The only way that you can actually study human growth is to actually, at some point, study humans, and you can't do it all in a laboratory. This is the first longitudinal measurement of a human growing, and it was during the French Enlightenment, de Montbéliard's son, and he recorded the height of his child every year as he grew from childhood to manhood, and rigorously recorded that. Tanner took his work and plotted it out in graphs showing his height over time, and then plotted out his growth velocities. And this is the first time that I think anyone had truly seen on a graph what the human peak height velocity and its timing looked like. And so you see Montbéliard's son had a peak height velocity somewhere around age 14, relatively typical for many males. This is sort of a schematic of what happens during the growth spurt. And the growth starts out incredibly rapidly when children are young, and then it slows markedly. During the mid-childhood phase, you have adrenarche, and the children will begin to develop a small amount of pubic hair with the adrenal androgens being secreted. But the real big change comes at telarchy. And with this, there is the institution of a large amount of an estrogen surge. And the first thing that you see, in girls, you will see the growth of the breasts, but in both boys and girls, you will see the hands and the feet markedly grow. The physis is incredibly stimulated by this estrogen. It's essential for the growth spurt. And so once you start seeing the hands and the feet and the breasts begin to develop more, you will see the child shoot up. They hit this timing called the peak height velocity, and then their growth begins to slow. Menarche is often used as a maturity indicator falsely in orthopedics. It occurs almost inevitably after the timing of the peak height velocity, and it's actually a fairly poor maturity indicator. About all it does tell you is that the child is past their peak height velocity. So it's a timing that you can note, but in terms of true maturity, it doesn't help you all that much. So in terms of human growth, there were a number of studies which were initiated in the early 1900s. Most of these were founded by the Rockefeller Foundation. Sadly to say, most of them were part of the eugenics understanding, and some of them have continued in that direction, at least in terms of their funding, though not with the studies. The major studies were the Boston schools, which some of you may have seen. There was the Harvard Growth Study, which subsequently came. There's an ongoing study in Dayton, Ohio, which is the Fells study, and I've had some involvement with those. Denver and Iowa both had some studies which have stopped over time. And the two that I'm going to speak to you the most about today are actually from Berkeley, California, and the BRUSH initiative, which was at Western Reserve, which has now become Case Western Reserve in Cleveland. These are the studies that have taught us the most about human growth over time. And I'm also going to speak a little bit about skeletal maturity as we go through this, because that's where we get most of our information. In terms of the orthopedic influence, the BRUSH study is actually the one where we get this whole concept of skeletal age. I'll speak a little more in detail about that. For us as orthopedists, and we're looking at limb lengths, we had information which came both from Denver and from Harvard. The Denver study was probably the stronger of the two. Unfortunately, all of the films have disappeared, and so we don't have much record of what happened there. The Harvard study was a weaker study. Their films have also disappeared, but they also made all the textbooks. So it tends to be the one that has stuck with people over time. So the BRUSH study is a fascinating study, and it was started in 1929. T. Wingate Todd was recruited over to Western Reserve University from England. He was an anatomist, he was a surgeon, he stopped doing surgery when he came over here, and he had this real interest and understanding how people developed over time. And he started two collections, which have become really critical for our understanding of humans. The first is his study on human growth, and this is the BRUSH study. They enrolled healthy children. They examined them every 3 months until they were 1 year of age, and every 6 months until they were 5 years of age, and then annually near their birthday afterwards. At each visit, the children had radiographs of their left hand, their elbow, their hip, their shoulder, their knee, and their foot. And they obtained a large amount of anthropometrics. They looked at their height, their weight, and all kinds of segmental measures. They have footprints. They did psychological testing at all of these. And they're all recorded, and they've all been held in the dental school up at what is now Case Western Reserve University. The other study that I won't talk to you much about was he began collecting patients who died in Cleveland and collecting their bones. And so there's a large osseous collection called the Heyman-Todd collection. So if you want to see what the bones of people who died in Cleveland in the 1920s and 1930s were like, you can go up there and you can do very detailed analysis of their skeletal systems. So the BRUSH study added children from 3 months to 14 years of age until 1942. Todd then published a selection of the hand radiographs as the Todd Atlas. About 20 years later, Grulich, who was at Case Western at that point, subsequently moved to Stanford, and Susan Pyle began collecting this and updating Todd's atlas, which became the Grulich and Pyle Atlas. And probably all of you are familiar with the Grulich and Pyle Atlas, which became the standard skeletal age term. So what Todd did is he took all of the x-rays on, say, a 14-year-old girl. And he took all the 14-year-old girls, which were a large number, several thousand in this series, and he would line them up from the least maturing looking x-ray to the most maturing looking x-ray. And he picked the one that was in the middle, and he called that a 14-year-old skeletal age. So it's the median appearance of skeletal maturity for someone of that specific age in Cleveland at that time. The study hit a snag in 1942 because we were in the middle of World War II. At that point, silver was desperately needed, and so the study ran out of funding and stopped in 1942. But we have really strong data of children from 1929 to 1942. These tended to all be children whose parents were educated. Most of them were Western Reserve faculty. Many of them, they all had to have a pediatrician or a family doc to be part of it. So it meant you had to be at least part of the middle class and well-nourished to participate in this study. The next orthopedic study was from William Green and Margaret Anderson. And they enrolled 100 patients, 50 girls, 50 boys, And they said that they had 51 normal and 49 with polio. And they instituted this method of getting x-rays of the legs so that you could actually get true limb lengths and estimate what was going on. We're not really sure that the other 51 normal truly were normal because the radiographs all disappeared. And then they took the Greulich-Pyle Atlas, which had been published in the late 1950s. This was in the early 1960s. And they used skeletal age to figure out growth remaining. And that proved to be quite useful if you wanted to slow down the growth of a leg by doing an epiphysedesis. You could refer to their charts and then to the Greulich-Pyle Atlas and then figure out when you were going to be doing your epiphysedesis. These are the charts that they had, and what they made the assumption of is that each child would continue to follow their percentile until they were done with their growth. So if you took a child who was at the 25th percentile at age 2, you would assume that they would remain the same percentile when they were grown. That would give you the length of their legs, and then you could estimate some timing for your epiphysedesis. So at least in concept, it wasn't a bad thing. So the next study that I think is of real interest is the Berkeley study. And they took every child that was born in Berkeley, California, every third child in Berkeley, California in 1928 and 1929, and they followed them to maturity. And Bailey, and you're probably familiar with Bailey's studies on childhood mental development, she was really one of the major drivers of this study over time. They obtained also similar anthropometrics to what was being done in the breast study, and they also obtained hand x-rays, which unfortunately have been lost over time. I've tried to find them and then have found out that they have completely disappeared from the face of the earth. And then in the 1990s, early 2000s, there was an orthopedist named George Paley, and he took a number of these these historic series over time, and he looked at what was their percentage of growth remaining over time. And so instead of calculating the child was going to grow 8 centimeters, he began looking at, okay, a child has completed 50% of their growth, or they've completed 75% of the growth, and came up with this concept of the multiplier. And the multiplier made it really easy for us as orthopedists to look at a child and where they were and figure out what their limb lengths were going to be at maturity, and then we could figure out what the differences were likely to be. So in his chart, what you see on the graph is that all of the various databases, if you look at chronologic age, they all fell into the same line and gave this same multiplier, which means if you have an 8-year-old child and you take a boy and you multiply their current limb length times 1.470, that's going to give you their limb length at maturity. You could do the same thing for height, etc. And he based that upon chronologic age. It made it easy. You got to get rid of the bone age. So this was all of the major work that I kind of stepped into when I began taking a look at what was happening with maturity. And what happened is that there were some real problems with the analysis of this. It was not the problem with the data itself. The data was collected longitudinally, but it was all analyzed cross-sectionally because that was the only way that people were able to statistically do it. So the methods of evaluating longitudinal data were not really developed until the 1960s to 1980s. And none of the data that has been analyzed that I've shown you up to now accounted for children changing percentiles during their growth. And the reality is that they do. And that makes it a real problem to analyze using cross-sectional methods, which is what all of those prior methods did. So here are 2 boys, and it's showing their velocity curves over time. These are a couple that I have the original data from the Berkeley series, and it shows their peak height velocities over time. So what you see is that one boy had his peak somewhere around age 11 and a half. And you have another boy who had his peak somewhere around age 17. So if you average out these and you just do cross-sectional analysis, what you see is that it really blunts out the peaks. And so if you do this for a large population, all you see is that the standard deviations increase as you go through this phase. You see that there is just a very nice smooth curve over time. So here's a practical example. This is the punt, pass, and kick contest a number of years ago. And these are all 13-year-old boys. Andrew Reed, who you see right there, won the contest. You can imagine being the 13-year-old boy next to him and going, I'm going to punt, pass, and kick against this. So kids mature at different ages, and it makes it a real challenge if you're going to try to assess that this young man, Andrew Reed, is going to be growing the same amount as number 22 down here. That is truly not the case. So this is the actual Berkeley series, and I've graphed them all out for you. And you can look at children's growth. The girls are maturing before the boys, so you see the girls in the lighter colors and the boys in the darker colors there. But you see that there's an infantile phase, there's a childhood phase, and then there's an adolescent phase of growth. And they are all a little bit different over time. So as I started out here, I mentioned the large size of the child's head and the fact that the mother would not be able to carry a child with that large a head and a large body at the same time. So the child all the children that are born are within a relatively limited size for the birth canal. And then they rapidly grow beyond that. The skull grows very fast during these first 2 years as the brain also grows. And so there's this rapid acceleration that's occurring of growth around the time of birth. Once you hit the end of the infantile phase, then growth begins to slow as you start hitting the childhood phase. And during this phase, children are very susceptible to growth stunting from malnutrition or for illness. But they can also catch up quite nicely if they are given good nutrition, they get over their illnesses, although prolonged illnesses will prevent that catch-up growth from occurring over time. There's been the push internationally for the first 1,000 days, which accounts for the days during gestation and this first early period of time because of all the important things that are developing during that stage. And hopefully this push will continue. It's really critical for children's development. So what's making children grow? Well, it is a single organ within the human body that is causing all of this growth, and it is the physis, or the growth plate. And the growth plate is an interesting organ that you have as a child and you do not have as an adult. And so as the skeleton elongates, both through the long bones and through the spine, it's this physis that is forcing the growth, and everything else is growing in stimulation to this pull that you are getting from the physis over time. The physis itself is a fairly remarkable organ, and it is susceptible to proprioception, or actually proprioception helps it keep growing in the same position over time. So this is just an example of how remarkable this is. The physis in a child can grow markedly over time. So this is a birth fracture in a child who has what looks like a shoulder dislocation, but it's actually a fracture. The growth plate itself has actually remained in place. So the fracture has happened here, and the periosteum that is in this area has remained intact, and the child begins growing another humerus. And this will disappear over time. That's why most birth fractures we can leave alone and watch them heal up beautifully, even if they look absolutely horrendous. The physis has several different zones. It has this proliferative zone, which is the zone that is sensitive to being disrupted and will cause a growth arrest. Fortunately, most fractures occur through this hypertrophic zone. It does not affect the proliferative zone. So most fractures that occur through the growth plate do not end up resulting in growth arrest. We can talk about some exceptions to that over time, but that's really something that's good that happens in younger children. The bone shape also appears to be genetically pre-programmed, and it's really dependent on proprioception. If you knock out the proprioception in mice, then you can knock out their ability to remodel. And proprioception both from the Golgi tendon apparatus as well as from the muscle spindles. So these burst fractures they heal quite rapidly. They rarely have any sequela. And if you splint them for comfort, they will heal up quite nicely. Their children are almost like salamanders in terms of their bones at this age. The other disorder that we see orthopedically in young children is hip dysplasia. Most benign hip dysplasia will resolve over about 2 weeks. So if you're going to refer children to us, about 2 weeks of age usually is pretty good because we can get a fairly nice assessment, and some of the neonatal instability has disappeared at that point. This is a radiograph of a stillborn child showing you the pelvis and how much cartilage there actually is. There's very little bone. That's why radiographs really do not give you a good picture of what's going on. From the hip's perspective, the sooner you get that hip in place, the sooner that you're going to begin forcing this cylindrical, spherical shape of the acetabulum, and the more rapidly that hip is going to form into a normal position. So roughly 2 weeks seems to be a pretty good time for us to be able to do a good assessment and then treat the child if needed here. This shows you what happens with the pressure of a femoral head. This is again from a stillborn child who had a DDH on the left side. This right side here shows you the triradiate cartilage of the acetabulum, as well as the cartilage here, and this is the acetabular labrum, the edge of it. And with the femoral head sitting here, you get growth inhibition of the cartilage in this area, and you get a wonderfully forming acetabulum. When the femoral head is not there, you get hypertrophy of this area and none of the formation that you would like to see around the edge of it. So again, getting the hip in early can help tremendously with this. The other severe disorder that we will occasionally see, it's much more rare, is infantile scoliosis. Scoliosis worsens rapidly during growth. Those two rapid growth phases are infancy and adolescence. And there are many small idiopathic curves that will resolve in neonates. But if it does not resolve and it gets worse, these are fatal curves. This is some data from Sweden, showing the mortality of infantile scoliosis compared to the mortality of the expected population. And what you see is the beginning in the late teens, and certainly massively accelerating by the time children are getting into their 40s. Curves that are of infantile onset can often end up being fatal over time. So we want these referred early to institute treatment if they need to. We have some nice science looking at which curves are likely to progress, which ones are not. And so getting them involved with us early can be quite helpful for these. The next phase is childhood growth. And during childhood growth, it tends to be relatively linear. And children undergo this process of canalization. And I think this is where the concept that children don't change their percentiles came from, because children don't tend to change their percentiles much during this phase of growth, but they still will. It's much slower than it was during infancy. It's relatively linear, and they can still undergo both stunting and catch-up growth during this phase of time. So this is again from the Berkeley series. And if you take a look at this from about age 3 to age 10, what you see is that the growth is relatively linear, but it still wiggles up and down here and there for individual children going through this. This is a graph of their percentiles over time, and you can see that they do bounce up and down. Clearly, once you hit the adolescent growth spurt around age 10, then things really go cattywampus. But you still see the going up and down of the percentiles as children go through their childhood growth. So during this time, the things that we classically see in orthopedics are things like Perthes disease, knock knees. Occasionally we'll see bow legs at this time. We will certainly see our children with skeletal dysplasias, and they come in out of the normal height percentile ranges. And we'll also see limb length differences. During this slow growth phase, it means that most of the deformities worsen much more slowly than they do during adolescence or during infancy. Fractures at this stage are usually low energy, except for the elbow, the supracondylar humerus fracture, which all of you are probably familiar with, which is a quite common injury in children at this age. Their elbows tend to be fairly thin, right at the supracondylar area. The children can hyperextend their elbows, and so it simply hyperextends, levers across this relatively thin area and fractures here. So human growth is predictable, but the reference that you need to do prediction changes over time. So during this early infantile phase here, you can use childhood age as a reasonable predictor. During this childhood phase here, its growth is relatively linear, and you can simply estimate a child's growing linearly now, and they're going to grow linearly until they start to hit their growth spurt. But during the growth spurt, you see the peak height velocity occurring here. Growth is incredibly non-linear, and you cannot use linear calculations to figure out what's going to happen with growth during that time. So what can you do to evaluate maturity and evaluate growth over time? So age works really only well before the growth spurt or after someone is done growing. And the problem really is the timing of the growth spurt. So girls mature about 2 years before boys do. And within the sexes, it is not homogeneous to chronologic age, and there's about a 2-year standard deviation. So the Andrew Reed that I showed you next to number 22 in that early slide is very common for children who are going through their growth spurt phase. You cannot compare them based upon age at this point. You can use Tanner staging. It's less variable than the chronologic age. It correlates really well with where they are in their maturity scales. The more scales make it much more precise, but it's really only as good as an examiner. I gave a talk similar to this that was sponsored by an orthopedic manufacturer, and they sent this to their company to make sure that everything I was saying was in line with the regulations they have on the company. And this was the slide that I was actually allowed to show. So it's probably not bad for orthopedists because that's probably what orthopedists should be seeing anyway. And so Tanner stages are probably good for pediatricians. You're welcome to do that. But I really think that this is not what orthopedists should be doing. It can land you in hot water, and we can avoid that. So how much can we rely on age? And this is, I've taken the Berkeley data again, and I showed you the multipliers early. And this is a calculation of height multipliers for boys in the Berkeley series. So I took a 13-year-old boy. And this is, if you look at the deviation across the multipliers for a 13-year-old boy, you see it's quite wide. And so the range of that for a multiplier is anywhere from 1.03 to 1.21. So if they're 5'1.5" right now, that gives you a prediction that they're either going to be anywhere from 5'3.5" to 6'2.5". I'm not sure that's a very helpful prediction for anybody. So the multiplier, if you're going to use what Dror Paley showed with that, yes, it's fine based upon age if you take large series, but that's only because they're based upon averages and cross-sectional data. To use longitudinal data and get more accurate predictions, you can't do what they did. So this is from the Brush series. I was fortunate enough to be able to get access to the Brush series a number of years ago, which gave us access to the x-rays and to all the anthropometrics. And so we plotted out the percent of growth remaining over time and compared it to the timing of the peak height velocity. Our hypothesis has been that timing relative to the peak height velocity is a far better maturity indicator for children in their adolescence than using chronologic age. Each of these, if you remember from the Brush methods, each of these measurements were obtained at yearly visits during adolescence. I wish they had obtained them every 6 months, but that's just what it is. And so we plotted them out. And what you see is that 90% of final growth occurs at the timing of the peak height velocity. So I like to play with shapes a little bit and was starting to go, well, I wonder if you could standardize it based upon the 90%, because it seems like 90% is pretty good for an estimate of the timing of the peak height velocity. So this range across here is less than 2 years, and since the heights were measured every 1 year, it seemed like a very reasonable thing because we could not get more accurate than every 2 years. And if you do squeeze them together, then what you find is that children have an almost identical growth pattern as they hit that adolescent growth spurt. So from just before the growth spurt to the end of growth, children's growth is nearly identical. So this is from the Brush series. We compared this to the Berkeley series and came up with the same thing. We've had access to the Fells series and have found almost identical information from this. So what it turns out is that children are widely variable as they're going through this rapid early stage, and then children's growth pattern in terms of their percentile or percent of final growth becomes incredibly similar as they go through the adolescent growth spurt to final maturity. That makes growth as you go through adolescence based upon peak height velocity timing incredibly predictable. So you can use linear growth and age during childhood and infancy, but you have to go to peak height velocity timing or the 90% as a substitute for that as you're going through adolescence. We looked at the multipliers and the predictions of it based on age versus chronologic age. And this is if you use the age-based multipliers here. This is for height. And so if you use the age-based multipliers, which was cross-sectional data, you find that they're not too bad in terms of the standard deviations of the error that you have, 4 or 5 centimeters or so, until you hit the adolescent growth spurt. And then, lo and behold, this tracks what looks like a normal growth velocity curve. And as you hit mid-adolescence, that's when you have the most error from using age. On the other hand, if you use peak height velocity, it's pretty lousy as you go through childhood and early onset and infancy. But once you start hitting the growth spurt, it becomes incredibly predictive with a very low standard deviation. And this is the same thing for girls. So for both boys and girls, use age currently as you're going through infancy and childhood. But once you start hitting growth spurt, you have to go to something different. So what can you use? And again, our hypothesis is that the skeleton reflects this quite well. So can you use skeletal age? I hate the term skeletal age, by the way, even though Todd came up with it, and I'm very appreciative for all of that Todd did. But the bones are really not a different age than the child is. This is simply a maturity scale. So I would prefer skeletal maturity as a term rather than bone age, but that's what we've all grown up with. So it's a misnomer, but there are many areas of the spine that are of the body that can be used as an indicator. You can use the pelvis, you can use the knee. We found you can use the ankle, you can use the foot. There's other hand scales that have been developed. Tanner developed one. There's a Fells method for the hand also. So several different methods are out there. I became really interested in all of this with growth because of what it meant for scoliosis. And that's where I began my research with this. Because we knew that if you were immature and you had a larger curve, your prognosis was likely to be much worse. But we really didn't know, what does a larger curve mean? What does immature mean? What does more mature mean? And so I wrote a grant many years ago, which probably wouldn't be funded now because it was a complete shotgun approach to doing things. But this shows you an example of what happens with scoliosis over time. So this is a girl that was followed for a number of years. And what you see is that for many years, many months, this curve really does not change very much. And then lo and behold, at one stage, she begins to go through her growth spurt. And during this growth spurt, the scoliosis takes on a completely different behavior. And you begin to see it increase, and it increases rapidly over a really short period of time. So something has happened, and this is what got me very interested in how can you measure maturity and how can you measure curve magnitude and actually get something that's going to be useful. So I got together with an endocrinologist up at the University of Pittsburgh. He's actually now become a geneticist, but he was an endocrinologist at that point. And we looked at a number of different hormone levels. We looked at skeletal maturity, and other bone markers to figure out what actually would be useful. The standard thing in orthopedics that we've used up to this point was the Risser stage, which is a sign on the pelvis. And what we found is that bone age actually outperformed all of these. I didn't know much about the Tanner Whitehouse method. I had to learn how to use it. I'd been using the Gorilla Compile Atlas. I was told it was a lousy book. It would only apply to children in Cleveland in the 1920s and 30s, and they were all malnourished. And as you now know, that part of it wasn't true. Well, orthopedists are not quite smart enough to read through the Gorilla Compile Atlas and figure it out. So I had to come up with something that orthopedists could actually use. And I'm going to teach you a little bit how to read a bone age if you would like to, so that you don't necessarily have to rely on the radiologist to do so. They're not that hard to read. I started looking at the wrists when I was taught to do that, but I've learned over time that that's actually not what you need to do. What we found with scoliosis is that the time that these curves really got worse had a specific appearance on the x-ray. So this is the phalange. So this is a middle phalange here, and this is the epiphysis, and this is the growth plate right here. During the time when these curves got worse, what you see is that there is this little capping, these little curlicues of the epiphysis beginning to curl around the metaphysis. That's when scoliosis got worse. And remarkably, it did it for all of the patients whose scoliosis was worsening over time. We were able to use these stages and predict scoliosis behavior quite well. It has now become the standard method for predicting scoliosis behavior for pediatric orthopedics. To read a bone age, again, term I hate, but we'll use it. You need to know several stages, and then there are simple stages that even an orthopedist can do, okay? So the first is that the epiphysis itself is not as wide as the metaphysis. That's uncovered. The second, it becomes as wide as the metaphysis, it's covered. Third is that it has these little areas which come around the edge like a cap. It's called capping. Then they start to fuse and fuse. So that's all you need to know to read a bone age really accurately using the Greuel-Compile Atlas or any other system for that matter. So I won't read through this, but I'm going to take you through a few examples on how you can do it. So this is pre-growth spurt. The digits are not yet covered. They are, if you look at all of these epiphyses, they're not as wide as the metaphysis. This child has not gone through their growth spurt yet. There's no thumb sesamoid. That's another thing that could be a little helpful for you. But the latest age that you see this in girls is 8 plus 10 in the Greuel-Compile, and it's 12 plus 6 in the males. So if you're seeing these as wide, you know you're beyond that 8 plus 10 and 12 plus 6. I would tell you, I don't think skeletal maturity is very helpful for kids below this. It's too variable for what happens with children. Skeletal maturity coalesces as children enter into the growth spurt, and then it becomes very standard relative to the growth spurt. Early in the growth spurt, they all become covered, and the last one to become covered is on the 5th digit, right here at the middle phalanx. So I pull up an x-ray really quickly, and I just look right here and see, is it covered? And if it's covered, then they're all covered. It makes it really easy to do. A number of other things that you could look at. But this is at the beginning of the growth spurt. And in the Greuel-Compile Atlas, that's age 10 in girls, and it's age 13 in boys. And then they begin to cap. And as they cap from proximally to distally. So the first ones that you will see cap are in this area. And then they will go toward the distal phalanges, and it goes from proximal to distal, and except for the radius, which is the last of all to cap. And this begins to occur at 11 in girls and 13 plus 6 in the Greuel-Compile Atlas in boys. And then the distal radius is the last of these to cap, and that occurs at 12 in females on the Greuel-Compile and 14 on boys. These are just the next pages as you begin turning the Greuel-Compile Atlas. And then finally, everything starts to fuse, and they fuse from distally to proximally. So they start fusing at age 13 in girls, 15 in boys. They are fully fusing on the distal phalanges at age 13 plus 6 and 15 plus 6, correspondingly in girls and boys. And then the rest of them fuse much more slowly. And the growth is really slowing down at this stage. 14 females, 16 males. And then everything but the distal radius is open, 15 females, 17 males, and then everything is finally closed at 17 females, 19 males. So this shows you the differences in the growth spurt and where the kids tend to be. So I don't think you should leave skeletal age to the radiologist. I think even pediatricians and even orthopedists who are not as smart as the pediatricians can do this well. So how close is the skeletal maturity to actual maturity? We know that we all start out relatively very immature, and somehow everybody ends up quite mature. Does everyone mature through the same pathway? And the answer is yes. And I got started in this looking at the brush collection, looking at elbow films. We began comparing subjects in that series to the timing of their peak height velocity. And so we looked at 2 years before, 1 year before timing, back to peak height velocity 1 year afterwards and 2 years after. So we looked at the elbow films at each of these different visits here. And we used a fairly complex method called the Savagrain, which is an elbow maturity method. It's a scoring system. Nobody's going to ask you to read it. And what we found is that there was quite a bit of variability in the chronologic age. You see the timing of the males and the time of the females. Again, about 2 years difference in those, but about a year standard deviation in each of them. But then when we looked at the scores relative to these, if you were 2 years from the peak height velocity in a male, this was your score, and this is a very small standard deviation. And if you look at the girls' scores, they're almost identical to the boys' scores. So what you're seeing is that there is no difference in girls and boys in terms of their skeletal maturity in relationship to the peak height velocity on the elbow. We've now seen the same thing for the hand. We've seen it for other parts of the body. We compared it on the hand. We published this in scientific reports looking at the stages that we described of the hand compared to the percentage of height remaining. So this is that same graph that I showed you compared to 90%, where everything has been standardized based upon 90% of final height. And you see that the stages are incredibly consistent with where the child is in that adolescent growth spurt. So skeletal maturity is a very reliable way of assessing where a child is within their growth spurt, though it's not before then. All of these various systems can talk to each other, so we can use skeletal maturity of the hand, we can use it of the wrist, we can use it of the elbow, we can use it of all kinds of other things, and cross-talk one to the other, because the children are maturing very similarly as they go through their growth spurt. We can start relating them to each other in this fashion. This shows you the timing of peak height velocity, and this is from the brush series, and this is timing of menarche. And it's a standard deviation occurring about a year for the median of these after the timing of the peak height velocity. But you see that there are still a number of girls who are not having menarche until about 3 years afterwards, and there's a smattering that are occurring just before the peak height velocity here. There might be better methods of looking at maturity. We're investigating one with the Shriner's grant from Portland, Oregon, looking at type 10 collagen, which is a breakdown product of normal cartilage. It's found predominantly in growth cartilage, and so it's now being used. We're testing it as another maturity marker to see where children are in their growth spurt. So this plots the multipliers over time from the brush series, looking at the spine and the extremities and overall height. And what you see is that the extremities mature before the spine does. So the maturity of the legs will have less growth remaining at any specific stage than the spine does. The spine is the last portion of the human body that continues to grow longitudinally. So children will shoot up their trunks during this adolescent growth spurt. So we think that the type 10 collagen may help us with some of this, but don't know for sure. So there are a number of disorders which are occurring during the growth spurt. Subcapital femoral epiphysis occurs probably because this estrogen surge that you were getting to increase the growth makes the physis white. It's growing like crazy, and it makes it weaker, so you'll go on to slip. Scoliosis of all etiologies worsens during the growth phase. Children at this age are growing a lot. They have higher energy fractures more often through the growth plates, and at this stage, because they're higher energy, they're more likely to end up damaging that proliferative zone and going on to a growth arrest. Hip dysplasia that is appearing at this time is likely to become symptomatic because of all the increased activity and the body mass that these children have, because they are growing like crazy during this adolescent phase. So you can see the hip dysplasia, which will go on to need a total hip at some point. So what have we learned over time? We've learned that the growth rate really affects the musculoskeletal system in different ways depending upon the stages. The rapid growth of infancy and adolescence makes certain deformities worsen. The physis is the part of the body, it's the organ that drives longitudinal growth, and it has a marked ability to remodel. Beginning in early adolescence, the best maturity indicator for growth prediction changes from chronologic age to peak height velocity timing, and that corresponds quite nicely, fortunately, to skeletal maturity. Peak height velocity does correspond to 90% of final height, and there may be other biochemical ways to assess maturity as we go forward. So I'm going to stop there and turn it over to you for questions, and I really appreciate your time this morning.
Thank you, Dr. Sanders. That was a great talk. It was very interesting. For everybody who's joined us this morning, you can receive Category 1 CME. So if you're signed in under a phone number or not your complete name, put it in the chat so Davina can record your attendance. And then I'd like to open it up for questions. You can either feel free to unmute yourself and speak, or if you'd rather type in the chat, I can read the questions for Dr. Sanders.
Hi, Dr. Sanders. It's Lindsay Chase, one of the hospitalists. Were these studies, did they take into account, I guess, racial and ethnic differences, or is it almost all just, you know, white children, like a lot of our studies?
Yeah, so that's a great question. So almost all of the children in both the Berkeley series and the Brush series were white children. So that did not account for any racial or ethnic differences. The children in Cleveland were of a different race, of different ethnic. They're from all parts of Europe, largely, but they were still primarily European in their origin. The Fell series has a number of African Americans who are included with that. The where I would go back and give you at least some insight is that the maturity scale that we've developed for the hand is being used in China, it's being used in Japan, and it seems to have equal applicability for all of those. So what I think we're actually seeing on the skeletal maturity side of this is that the skeletal maturity is closely related to the peak height velocity timing, and that's a human factor. It's not a racial or ethnic factor. Children may mature at different times, and you will see that in different ethnic groups. A lot of it has to do with nutrition. Some of it can deal with just the genetics of the child within those. So I think that the fundamental things that we're finding about skeletal maturity, how that relates, and what happens during the growth spurt in childhood, they may occur at different timings, but that these are fundamental human things that are occurring rather than something just with white children that occurred in Cleveland in the 1920s and 30s.
May I ask just a quick question? We always get question about how tall do you think my kid is going to be? And so are you saying, and I'm sorry, I was listening to this while driving. Are you saying that the best predictable tool is with the peak height velocity and a bone age together will give us the best answer?
So the best response to that is that peak height velocity appears to be the best maturity marker for someone going through their adolescent growth spurt. And peak height velocity reliably occurs at 90% of final height. So if you can truly identify the timing of the peak height velocity in a child, you can fairly reasonably predict they were at 90% of their final height. Unfortunately, you rarely get that opportunity. And so you have to rely on some other scale because someone will show up to you a year before their peak height velocity, a year afterwards, or wherever. You don't know where they are. Skeletal maturity can give you a good indicator of where they are. And that's where you can hopefully be able to use multipliers or methods that use skeletal maturity to give you a good prediction of their final height. Does that answer that okay?
Yes. And are we going to be able to review the slides? Will you be able to share your slides?
I get. Listen, Gina, you got a copy of them, right?
Possibly. I'll look for it. If not, I'll reach out to you.
Okay, we'll get them out to you.
And it looks like Dr. Gala had a similar question to Dr. Chow. Can you explain how to use the peak height velocity correlating to 90% of final height using an example? Of course, a question pediatricians get all the time, how tall is he or she going to be?
And we have people coming to us all the time saying, can't you just get an X-ray in my hand? I want to know how tall I'm going to be. And then I can usually disappoint them by saying, I'm sorry, you're not going to be so tall. So maybe you'll end up short like me in the end. So the best way actually, so if you can truly identify the timing of the peak height velocity, it's great. It's really hard in an individual child. And when we're doing it in populations, we're doing the second derivative of the growth curves. And so you're trying to identify when those are changing. And there's a lot of variability and a lot of error because you're not seeing the child on a daily basis to be able to actually measure when the peak height velocity occurs. Fortunately, skeletal maturity correlates really closely to the timing of the peak height velocity. And that's what can help you the most. And I hate to go back to the Gorilla Compile Atlas because I'm not sure that you can rely on where children are following those percentiles. But as you get into the adolescent phase, it's pretty good. We'll publish some things that'll give you better data, but that's okay.
Any other questions from anyone this morning? All right, well, thank you so much, Dr. Sanders. We really appreciate your time for joining us this morning, and thank you all for attending, and we'll see you next month.
Thank you very much.
Thanks a lot.
Bye-bye.
Thank you.